morning.
Morning.
So I have been waiting for a year to do this, so I'm so excited. Haven't had to dress the part, obviously. Our guest speaker this morning is Bob Kasworm. He first visited Tanzania in 2001 as an affiliate of Untitled Health, and in companionship with the Nebraska Synod, he went to evaluate the potential of Allegiant in assisting hospitals, dispensaries, and the existing public health programs in the area of Tanzania. He says that from his very first trip, there was rarely a day, and sometimes not even an hour, when Africa was not on his mind. He made a dozen additional trips to build relationships and to begin partnering with the hospitals, clinics of the Northern Diocese of the Lutheran Church in Tanzania. And at the end of 2004, he relocated to Tanzania full-time for a planned 2 years, and he's been here ever since. Bob is the director of the CHI Lutheran Hospital, which sits at the base of Mount Kilimanjaro. It's kind of a rocky, hilly area, kind of rugged. Terry and I met him on our first synod trip that we took in 2007, and then we visited him again in 2009, and he made dinner for us. Yeah, it's a good. Well, he has a variety of other responsibilities associated with the hospital. It was he who envisioned and developed the Houses for Health program and the Nurse Scholarship program. These are two of the programs that we support at First Lutheran through the Synod when we have our Gifts of Hope in December. I always remember me on those pushing for those two programs. Near and dear to my heart. Bob holds a degree from the University of Iowa. He and his wife Lynn are members of Lord of Love Lutheran Church in Omaha, and they have 2 adult sons. And while Bob is our speaker, it is also with great admiration that I present to you his wife Lynn, because behind every great man there's also an equally great woman who keeps the home fires burning. So, Bob Kasworm.
Just to get the first correction, I did not go to the University of Iowa, I went to the University of
Utah.
I noticed this morning there's a lot less graduates from the University of Nebraska, or at least it claimed to be. It's great to be here. I've been back in country for a couple weeks, and I have 1 more week to go. And we've had a nice friendship develop with Terry and Karen, so I'm happy to be here at First Lutheran. So I'm just going to kind of run through stuff and kind of how it happened, and it'll kind of be in different directions, but hang with me. One thing, you know, in Tanzania there are 6 million Lutherans, so more Lutherans in Tanzania than all kinds of Lutherans in the U.S. now. So there's one, but one thing is pretty common, they usually sit in the back. That was imparted by the missionaries, I guess, I don't know, but some of that's pretty common. So we are there really under the part of the Companion Synod program, which is part of global mission of the ELCA. So almost every synod in the U.S. has 1 or more international sister churches, you could call them. And the days of the mother church, daughter church, superior, inferior, those are long gone, so it's called companionship now. And it just so happens Nebraska Synod has 2 partnerships. One is Uruguay and Argentina, which has not so many Lutherans there, but a few. And the Northern Diocese of the Lutheran Church in Tanzania, which has about 600,000. So quite a few more of them there, and in a very small area geographically, the diocese that we work with. It actually sort of began in 2001. So as part of this Companion Synod program, which actually with Tanzania, it started with, before Bishop DeFries, in fact, had originally started, and not much had happened. But when Bishop DeFries came in and assistant to the Bishop, Martin Russell, they had both been in Tanzania. They were very wanting to build the program. One of the things they did is they came to us. We were at that point Allegiant Health. You may remember it used to be a Catholic Lutheran partnership. And they came to us and said, we've been talking to the people over there, and they asked if there was someone in healthcare that would like to work with them under part of this. And so our questions were 2. One is, where is Tanzania? And the other one was what's going on in healthcare there, and they said, well, here's where it is, but we don't know where church folk. You need to send someone to check it out, see what's going on. So I had never been anywhere, never any interest in international work or development or anything, but I went. And I thought it was because my old background was partly clinical and then partly administrative. I'd done a lot of things. So I felt kind of good about being selected, but later I realized that it was actually, they thought, we're going to send someone to Africa. They may never reappear. Who's expendable? Bob. We'll send Bob. And, but the kind of the surprise was, of course, after going there, quite to my surprise, I never ever really came back. Okay, because my mind, as Karen said, was working on it. And there were a couple others of us in the synod and stuff that kind of had the same feeling, and we fed off each other, and things got going. So anyway, we went there, made a bunch of trips, started some small programs, surplus goods, things like that, just trying to learn, because we knew we really didn't know much. A lot of people go to something like Africa to tell them what to do. That doesn't work. You need to spend most of your time, even today, listening and learning and understanding that you're going to be getting kind of effectiveness. In the Northern Diocese, KKKT, don't let the KKK worry. That's Tunisia, the Julie Kilutari, and Evangelical Lutheran Church of Tanzania. And you see these signs everywhere. But they have 3 hospitals, 24 dispensaries, and a public health program, and that's who we would be partnering with. And again, the companion synod model is one of accompaniment or partnership or shoulder-to-shoulder walking along. This is a bishop. This was a change of the board, and the new board at the Machame Hospital a few years back. And but this is Machame Hospital in 1906. That's Dr. Plaus. He was the first physician there.
I thought it was you.
No. But that house still stands, and it's right next to my house. The slight quick history. So Tanzania mainland was Tanganyika. It became German East Africa when the Europeans divided up the continent colonially, and the Germans got there and did some brutal element of colonization, but right hand in hand with that was the missionaries. And so Tanzania looks a lot like Germany looked like at that point, so about half Lutherans and half Catholics. The Lutherans and Catholics back then did not get along, so the Germans being very organized, they divided up geographically where they could go. And the Machame area became all Lutheran, and it was started by Leipzig Mission. And they continued there for many, many years. But when they came, it was up on the mountain. The people didn't even speak Swahili. It was tribal language. It was real, and it took decades before they got to the language figured out and even to the first believers. So it's very historical. And I live in a 102-year-old house, one of the first big houses built there. Anybody that's been there, or any of you that come, you'll get a chance to have that tour of the real history of the place. But where in Machame was the center, and the church, the Lutheran church, spread in a number of different directions from there. But they also built a small clinic, 1905. It was the first hospital. It was to take care of the missionaries and their families. And then after a little while, the first believers, and after a while, everybody. And so what that really remains now. We're about a 200-bed hospital. Brenda says about 150, have several hundreds outpatients, and a lot of stuff going on there. We have educational programs we'll talk more about. But it's kind of interesting. This church began First Lutheran in what year? 1870 something? I read your history. You don't know, but it was only about 10 years different when this first church was going on there on the side of the mountain. Many of our hospitals in this area are not older than 1905. So this was all going on there. The hospital was run by the German specialists for decades and decades as part of the mission. In 2013, politically, something happened, which was Allegiant Health, which used to be half owned by Catholic Health Initiatives and half by Emmanuel Health Systems, which was Lutheran. The Lutherans sold their half of that old health system. And so now actually I work for CHI Health, which is a total Catholic nationwide system. And of course Emmanuel took $500 million and they have it there. But as part of that agreement, one of the deal breakers was that CHI would continue this ministry for no less than 10 more years, and Emmanuel will put in half of the operating costs. So we've got 6 more years for that to run. So this is getting to be a long-term thing, and actually very big interest through CHI still. So even though we're mostly dealing with Lutherans and they're at the heart a Catholic group, has made no impact whatsoever. In fact, actually early on, some of the sisters were the most supportive of this program, and the only person who ever spoke against it was a Lutheran. I have an oversight committee, and we have representatives from Emmanuel, so that's that parent group. We have from CHI Health, we have Martin Alley, who's kind of the volunteer coordinator for all things Tanzania with the synod appointed. And then Dave Christensen, who's been with us from the very beginning, and myself, and that kind of keeps over. So the operating funds are 50-50 CHI Health and Emmanuel. But what I would say is that just is to, basically pay for me and the fuel for the truck and stuff. Everything else we've done almost has been through donations, and 100% of any donation goes to the project, because there's no overhead, zero. So there's not that 12% or 83% or whatever it can be on them. So if you give a nickel for something, it goes exactly for that, which puts us in a very nice position there. Okay, so first few years was kind of that learning, relationship building. I took a multidisciplinary team, so a surgical nurse, a pharmacist, an accountant, a building and plant engineer guy, very important to really try to learn what was going on and understand the environment and the facility we were working primarily with in Machame. One of the early things, surplus goods, this was a pickup or a packing up one of our warehouses of surplus items and equipment and sending a container. It was okay, but we learned some things. But, we sent a lot of junk as well. We didn't think it was junk, and we knew something. We were trying to be careful, but as I always say, junk for Jesus is still junk. But we've gotten better. And then in 2004, a certain grant process became available to us. It was called Community Health Benefit Grant. Honestly, I think it was to help protect our not-for-profit status, because we were making too much money back then, and so it was. But they didn't know that a few of us would define community to include Tanzania. We asked for a lot of money. I didn't think they'd give it to us. I thought they'd give us a little, and then they gave us a lot of money, and that meant someone needed to go manage it. Really, you couldn't just from distance. So I agreed to go for 2 years as a loan executive in contract, totally written to be able to go back to my other work back with the hospitals, but so over there I'm appointed a health advisor by the bishop to the diocese. I'm kind of an associate administrator. I don't run the hospital. Okay, it's all Tanzanians there except me currently, but I'm kind of a key part. But I'm the longest serving of the leadership group now there. So, and when you go into a new place, you're the new guy. But when you get to somewhere and someone's already there, you expect you sort of figure they belong. Well, I've been there longer than all the rest of them, so they've all come in and they figure I belong somehow. So, Orthopedic Center is something we created. I'm actually your commissioned representative of the Nebraska Synod. So when I was going to go do this for a couple years, they said, well, why don't we, I thought it was like a farewell or a send-off at the Synod office, and then it turned out I sort of took some kind of vow or something. And it was a bit shocking to me. And then actually, because of that, there's a category for ELCA Global Mission called Global Mission Associate. And that means they don't pay you, but you get to have your name in their book. And it's nice because there are a few other folks in Tanzania, and I get to be in that network with them as well. So, so I have all that stuff there, but maybe we can talk a little bit about. So working in Africa, well, the number one thing is it's a very low resource environment. So I was just shocked here. You have these little safety plug covers here for your electrical. So we usually just stick wires or hook them together and stuff. You know, all of this, it just isn't resources to be able to take good care of almost anything. So that's always a challenge. There's never enough money, never enough anything. People are generally very poor. I think, you know, they live average person on $1 to $2 a day. And yeah, so, you know, you can kind of envision and welcome over and to really have that experience. There's not much infrastructure, so electricity is kind of spotty. It's not dependable. It comes and goes. Roads, certainly medical care is iffy. You don't want to be ill there. So if you're feeling like you might want to be ill, don't come to Tanzania, please. We do have people come, and they usually end up, then I get the call, and I go, what are you thinking? But anyway, as someone close in there. And we can do some pretty good care, but you're not going to get the nice, comfortable, nice things like you would know. Where it needs to be clean, it'll be clean, but we're not going to have etched glass windows and all of that kind of stuff. And anyway, a big part of it is cultural differences. So there's, of course, we're dealing with different languages. Mostly we speak Swahili, and I kind of like that quite a lot, but that's a challenge. But they're just different ways of looking at things in the world, and one you learn over time. One way isn't necessarily more right or more wrong, but it's different. And so you make assumptions, and everyone else makes assumptions, and then you have these cultural meltdowns that occur. I'm on to number 24 currently. And then there are some other barriers. There's certainly corruption and bureaucracy. They go hand in hand, and then there's bribery, but there's also a whole bunch of loyalties. So loyalty, you know, maybe to your high school, or but there it's certain tribal groups, particularly clan and family, and that supersedes other things. And here we have that to some degree, but not by so much. Anyway, plenty of challenges there. Let's talk about healthcare. So healthcare, we always think, is a very different animal. Terry, can you tell me what that animal is?
It's Elon of some sort.
Yeah, close. Karen?
Well, sure, I was going to say an antelope, so what would I know?
It's a topi. Remember the topi?
There you go.
Okay, it's a different kind of animal. What we say is poverty leads to poor health, and poor health leads to poverty. So it's a spiral that gets going, and you can come from being very poor and go the other direction, or you can start not so poor, but once you run into bad health, there's not the whole social security structure and all of that. So just to put things in perspective, so it has one of the highest maternal death rates in the world. So if it's, and you can get numbers anywhere from 1 to 10 to 1 out of 164 women will die from childbirth related issues. US, it's 1 per 2,700, and the US is not leading the world by any means on that one. So you get numbers in Tanzania as a whole, about half the births are done at home, half in some kind of health facility. But the country is very different from place to place. So in the Bichame area, we have some roads, we have a little bit of educated people because of the missionaries being there for 100 years ago starting. So we have many more births in facilities, but it's still plenty. But just to kind of give you an idea. Also, again, it depends on the part of the country, but certainly between 1 and 2 out of every 10 children will die before age of 5. Some areas much worse than that, so, but it's just how it is. Again, it's resources, it's transportation, it's education, all that goes into that. But that's the kind of gives you a little bit of an idea. And as well, Tanzania ranks number 7 from the bottom in healthcare workers per capita. The number for a long time was 1 physician per 25,000 population. it's not so bad because we've got a couple new medical schools for the last number of years. I think it's one nurse per every 2,800 people. So obviously, they're high need for workers. We can't talk about Africa without spending at least 2 minutes on HIV/AIDS. Everyone knows this was the epicenter. This is where the virus originally appeared. And you can see sub-Saharan Africa has a very high percent of those people compared to their size of population in the world as well. Just to give you some remembrance, so this is from the years from the 60s, the 70s, so life expectancy was going up and up and up as development came in and all that went along with it, and then took this crash down as the impact of HIV/AIDS was felt in Africa as it came on. That's South Africa, Kenya, Zimbabwe, Botswana, so just to give you an idea. But it has giantly changed from my time there, because when I first went, people with the virus, it was seen as a death sentence. Just a reminder, it's acquired in Africa. It's men and women, women and men, sexually transmitted. That's the source. And you get the virus, you probably don't feel maybe a little sick, nothing, and then it goes latent for 6 or 8 or 10 years, and then you start showing up with some infection you shouldn't get, pneumocystic pneumonia, yeast in the mouth, and then as your immune system's destroyed, you get, they called it the skinning disease, so it's a huge impact there in that country. And the church started out not very good on it. The church said, this is, you're reaping what you sowed. You've lived an immoral life, and now this is what's happening. But as time went on, everybody, and I mean everybody, if not themselves, lost fathers and mothers and sisters and brothers and children. And it's one case there where the church has come back and apologized and says, we were wrong, that's not our role here. Our role should be one of educating and supporting people. So, but you as Americans, through George Bush, he came up, he got excited about this, and created what's called the President's Emergency Fund for AIDS Relief in Africa, PEPFAR. And in Tanzania and I think 11 other countries, it's the prime source for funding for treatment for HIV. And this has had a huge impact, unbelievable impact, because although they don't have all the exotic and wide variety of possibilities of different cocktails of antiretrovirals, there is pretty much, and it has expanded out, a number of centers where people can get this. So our HIV rate is going down. It's probably not going down from a change of behavior, it's going down because so many people are under treatment, drives the virus load, they're not infectious. So that's a great thing. We've also gotten very good at preventing transmission of the virus from mother to newborn infant. That normally occurs at birth when you have the mix of the fluids sometimes, but it can also come from with mother's a nursing mother. But if you can get the treatment going, and at Machami we're down from 70% of children to HIV positive mothers turning out positive to about under 5%, probably right now about 3%. So that's probably about as good as we can get in our environment. But it's radically changed society, and you as Americans so far are helping to pay for this. There's some talk that they would like to pay less now, our president, so we'll see what happens there. Just to give you an example, this is the HIV/AIDS Care and Treatment Center at Machame. It's an outpatient building. We have about 1,400 clients. Of those, 300 or so are kids that come every month, get their checkup, get their meds. Mostly they do okay. We still have people probably every week die from HIV-related things, but it's nothing like it was. People can go on and have a life. They can get married. They can probably have a family. Think of it like juvenile onset diabetes. You're never cured. You'll always have to be taking stuff. There are other complications, but most people can have a life. This is just an example. These are all kids from that program. They're getting together. We get them together twice or 3 times a year. for a kids club so that they know that they're not the only one who is living with this virus and that there maybe the stigma, they have to be worried about it for that. So it's a support group and they get to play games and stuff and usually go home with a big pack of food and some things. So this is an example of just the basic Machame Hospital. You know, always when I give these presentations, the slides are dark. So I went through and lightened every picture for you guys, and you've got a great projector. And so, I'm sorry, but you can see that's a little pretty basic, right? You know, a cement floor and a metal bed and bigger wards. You know, I'm old enough to remember just the end of wards, you know, hospital wards, but here, barely. But yeah, so that's common, and it's just a very different environment. The family provides a lot of the care, personal care, and we don't feed the patient. The family also provides food for the family, or for the patient, and they can, if they're not from nearby, we provide a cooking place, which means a fireplace and water, and anyway, again, different environment. Now what we have, probably one of our biggest problems, is what they call the modern diseases. They say they didn't have these before. Uncontrolled hypertension, high blood pressure, and type 2 diabetes. We know our African American population tends to be higher in both of these, but there's actually some studies going on. But our particular tribal area where we are, it's probably double or more what we would expect for people of the same age here. And the type 2 diabetes seems to come in much earlier. And then in both cases, it's economics. So, you know, there's lots of old line and high blood pressure medicine that's very cheap. But, you know, if you're feeling okay and your choice is to spend a few dollars for that or a few dollars to eat or to get your kid to school, you just might not. And so we see people pretty high levels. So we have what comes from that, which is kidney disease from long-term uncontrolled, and hypertensive strokes are a real big source of pathology and disease and death in our area from that. It's something that could largely be changed. And the other type 2 diabetes is the same kind of thing. People that they also not aware, but also no one would have a glucometer, could test themselves 6 times a day and all of that kind of stuff. That would be very rare. So we are actually doing what we would do here maybe, but 20 years earlier. So the person has the bad foot that has to be, the toes have to come off, but they're 40 instead of 80, that kind of thing. So the modern disease is happening. The diets have changed, the amount of exercise has gone down. There's not much smoking, but that's and they have modern stresses, so they've moved into the modern world without some of the negatives. They're eating white bread instead of yams, all that kind of stuff. We have a couple of key partner projects, and these are projects between the CHI Health and the Nebraska Synod. So they're formal programs that we partnered together on that I administer. The first one we did was adopt a dispensary. Around the hospital, we have satellite clinics. So, you know, not 1 in 1,000 people have a vehicle. So you need health care close to people where they can get it. So we have these dispensaries called Zahanati, or little clinics in the village. And we have them anywhere from 2 miles away from the hospital to 70 miles away. And we have some oversight for them. What we found is that they were very key, because it's where the prenatal and postnatal care is given, where births happen if they're remote, it's other public health, it's where people go to get treated for very common things, which there might be malaria or worms or that kind of stuff, and they just need that. So we didn't want to run the clinics, but we thought one thing we could do would be provide them the medicines they need. So we ran for quite a number of years a program where different groups, hospital or a number of Lutheran churches in Nebraska and others just adopted one dispensary and would provide. It only took $1,000, $2,000 a year to provide the medicines that they needed. And then with that, the clinic could provide the medicine, they could sell it when possible, Then there was some money that helped pay for staff and that kept them going for a while. We've also pushed them to be more closely aligned with the government health system, and we've had pretty good success with some of that. But yeah, so here again is one of these clinics, a clinical officer's there, you can see the people, there's health posters telling about getting your immunizations and better nutrition and anti-domestic violence and all that kind of stuff. This is that was at Natigro. This is in Masama. And then they were actually having a board meeting, and these were boxes of medicines which we were actually delivering on that particular day. And just a couple of examples. So early on, I was actually delivering all of these, and so we get some African adventure. This is our truck, and this place had always been a desert that I'd gone through, and that day it was a swamp. And I wish we really got scary because of the water and stuff, but we plunged on, got to the place, and got back somehow. And later I heard from one of the nurses, she was explaining something. He called us, and we told him, don't come. Well, my Swahili's not so good. But they said, luckily he came right when we needed it, because that was just the disease period with all the water, the fevers, the malaria, etc. So it was a great blessing, but I wasn't going to do it again. So it was, as I say, always a good indication. Another program that came out by accident. Most of the good things happened by accident. The first one was planned. Actually, this was a lady. She had HIV and actually was in the 8th stage right when treatment came in. So she started getting the drugs. She got healthy. She had tuberculosis, which was very common. And she just come out of the hospital. And she had these 3 kids. Her name's Nectar Somi, and her husband had died the year before from AIDS. And these 3 kids and I got to know them from our clinic a little bit. And then I had a nice guy from Pennsylvania who came with a church group, and I said, well, you know, you go on the here and there, why don't you come meet a real family? So I introduced him. And he said, well, what's going on? I said, well, when I met them, the kids were just there on weekdays. Why aren't the kids in school? She says, I can't afford to send them to school. I said, but primary school's free. She said, well, yeah, but you got to have a uniform, and they got to have shoes in our area, and you have to take some corn and beans every semester. She says, I don't have a penny. And this guy said, well, can we help her? And I said, well, actually, I've got someone else who's got her the school thing handled and something else. But I said, the one thing that I'm not sure she can ever do well is this is her house. Her shelter is a dirt floor, and we're high altitude rainforest, so we're very cold and wet half the year, a lot. We had 1 week this year where we had 30 inches of rain in 1 week. And it can handle it. It's kind of, it's kind of used to that. But how are you ever going to get better if you got this? And he says, well, can't you do something about that? And I said, I don't know. I'm a medical guy. I don't know anything about that. And he says, here's $5,000. See what we can do. So we went, and I pick you out of we drew my kindergarten we looked at what other little houses were, and we came up with a plan to build a small house, dry house, cement floor, block wall, metal roof, just to get people out of the unhealthy situation. Just one step up. And so we built such a house. The first builder I got lined up, he never showed up. The second builder kept changing the pricing. So some things are the same around the world. And but the third guy was good as gold. And you can see cement floor, pretty basic, but 2 rooms. But it's just a dry house, safe, small. If we could build for the poorest of the poor, if we could build nicer, really nice houses, we wouldn't, because then you'd have jealousy and issues. No one would be jealous of someone getting the very basic. Well, we had enough money left over, we built a second one, and then I had to report back to people what I was doing, and everyone here was really excited about it. I wasn't. This wasn't something I was doing. This was just, one-time deal. But finally we realized we had a program, and it's called Houses for Health, building houses for people who have a health condition that's being exacerbated by their even by African standards, terrible shelter. Okay? So we said, yeah, if you want to do this, send us about, it's about $3,500 now, the exchange rate, whatever, we'll build a house. And it kind of went and went and went, and actually we've just completed our house number 131. We have 2 more underway. I have more coming. There's no end in sight. Everyone's sponsored, all from donations. Many churches, Sunday schools, individuals, friends and family, 3 attorneys from Houston for Christmas. I don't know, but word gets out. We have a website, Houses for Health. You can go look and you can look at every house pre and post. And I know here at First Lutheran that you decided to sponsor a house, and it was house number 115. It was Anita Kumaro, and she has 2 siblings that are a little older, and the parents had died from HIV, and the family had split up, and the house was no good. So by providing this better house here, our hope is that Anita was certainly there, and maybe we'll reunite the other family, because once you get a better house. So this is in the rainy season, so the house is still drying. And we used to, every house was blue, and somehow we changed. And this is more natural. It's a gray kind of a putsch, but again, it's the block wall. But mostly the design is pretty close. So that's your house. You've joined, many other people to build these, and I'm starting to get excited about it now. This is actually just another lady who lives a stone's throw from Anita. We built a house for her. She had HIV, but also had breast cancer and had a mastectomy. And so perfect person to be able to help them a bit. Most of these people could have lost all hope, and this is something good can happen, and it will actually help them. And that house will be there for 50 years. So as families evolve, it helps reunite families in many ways. So it's turned out to be a great program, and we've made a change. Now there's a brick factory place making kilned bricks not too far from us. So we've tried out a few of them, and we've moved to metal windows, which are actually cheaper than wood there now, or at least no more expensive, and we can put in glass. So now it's looking pretty good, but it's still the same floor plan and whatever, but I think the kiln bricks will be better. And yeah, so something's changed after 129 of them or something. Another thing I'd like to talk about then, orthopedics. We got very involved in this. They were doing none in recent years, maybe back in the old German era when the Germans ran the hospital for 7 years. But actually, Lincoln orthopod Pat Hurlbut came with his Southwood Lutheran group, which has a very strong relationship with one particular parish over there now that's developed. And he hit it off with the director of the hospital, and they talked about doing orthopedics. And so he actually brought Dr. Swy here and rode around with him for a month and lived with him to see. And we told Dr. Swy, if you want to do more of this, you need to have a better facility. He was trained as a surgeon in Russia, and he said, our people have better immunity, I can do this. And, well, when he came back from Lincoln, he said, we've got to have a better facility. So they started along to build this, and he said he could raise the money to build the building if we could equip it. And I recommended to my committee that they would never pull it off, and I thought it was a waste. But my CEO at the time said, Bob, if you leave them with a couple of new surgeries, is that the worst thing, really? So we said, okay. So we moved through, and again, you build it on site. And meanwhile, this was a group of people from here and from Global Health Ministries, which is in Minneapolis, which takes in surplus medical goods and sends them to former Lutheran mission hospitals around the world. And they're great to work with, and you may, if you ever get a chance, it's great stuff. But this is the back of a big green container. They have filled it all up with things for our orthopedic center. Here's the leaving Minneapolis. Here's the truck after being lost on the ocean. 3 breakdowns coming from Tonga to Kilimanjaro. Then we had it at the hospital, and we almost flipped the crane over. And I was at the end of my my robe. So at that point, your mission representative in Tanzania said some words they've never heard before. And I hope they never hear them again. But all's well that ends well. We have a lovely facility now, certainly amongst the best in the country. Everything was great. People said, oh, it's so great. It was such a big deal. The president of Tanzania came for the big ceremony. And then, well, nothing great is ever achieved without much ado. We didn't use it. Month after month. It was a time of anguish. Why? What is the problem? Whatever. And just work through. We had the nurse in charge who probably had too much. She couldn't handle the responsibility. It was too heavy for her. She could only see problems. There were other things we didn't have. We got Margaret Mrema as the chief nurse. And I said, what's the trouble? She said, well, we need some things. I said, you tell me and we'll get them. And then some of it was easy, mops and buckets, but the anesthesia people had to move a cart back and forth. They didn't like that, so we got another cart. And just things we worked through. It was very big learnings and stuff. But at the end of the day, about that was 2008, there was first day of surgery. Dr. John Limo is in the middle. He's a very qualified orthopedic surgeon, and he's with us to this day. And we've been on, and we've now approaching about 13,000th procedure currently. Mostly it's our local people, but we get occasional visitors. This is Dr. Steve Meyer from Sioux City, who's come to Tanzania many, many times. And he usually is with us a couple days, twice a year. We get along great. And he says this picture is proof that it's a low resource environment. Because that surgical cap is a Nebraska black shirt cap. And he is an Iowa graduate. He says this shows that people know I wouldn't wear that unless we were desperate. After it took off the surgery, we realized we needed to have a place for the patients. So we redid very old buildings into some mini wards. And in my thinking, we're going to have a male side and female side. Well, actually, the orthopedic surgery there is 85–90% male. It's all trauma, it's motorcycles, it's that kind of stuff. So it's most so. Again, we get people, we can build specialized wheelchairs, artificial limbs, etc. We've gotten involved in this. You are all medical people, so you can see there's something wrong with this femur. And what we're doing now is we're in a program called Sign Nail. And it's made for, here's one of these stainless steel nails. It's made for the developing world. It's a guy, Dr. Zirkel, out of near Seattle. Basically, you have to invest a bit in it, but then every one you use, they replace for free. And we were about at the end of our donated stuff. So they're different sizes. They don't require a C-arm. They have a special majoring, so they're made for the developing world. And we're approaching our 100th one of these. And I have to somehow sneak these into the country again.
We have a C-arm.
We have C-arms. Yeah, but they've got this system measured for doing it. So they're doing around the world. But it's been a great program for us, and especially we've been inundated by little Chinese, cheap, lousy motorcycles that are just causing carnage. Uh-oh. We need to keep going. Okay. And yeah, you see the numbers. And this is a kid. We do a lot of children too. For some reason, there's a lot of club feet, but also this kind of legs and this kind of legs. Send us about it's about $3,500 now. The exchange rate, whatever, we'll build a house. And it kind of went, and actually we just completed our house number 131. We have 2 more underway. I have more coming. There's no end in sight. Everyone's sponsored, all from donations. Many churches, Sunday schools, individuals, friends and family, 3 attorneys from Houston for Christmas. I don't know, but word gets out. We have a website, Houses for Health. You can go look, and you can look at every house, pre and post. And I know here at First Lutheran, that you decided to sponsor a house, and it was house number 115. It was Anita Kimaro, and she has 2 siblings that are a little older, and the parents had died from HIV, and the family had split up, and the house was no good. So by providing this better house here, our hope is that Anita is certainly there, and maybe it will reunite the other family, because once you get a better house. So this is in the rainy season, so the house is still drying. And we used to, every house was blue, and somehow we changed. And this is more natural. But it's a gray kind of a push, but again, it's the block wall. Mostly the design is pretty close. So that's your house. You joined, many other people to build these, and I'm starting to get excited about it now.